to 1:30. We think we can get by with an hour for lunch to kind of pick up some time and not have to reduce too much time. We'll try to ask you to be prompt back from breaks and lunches so we can try to get back on time again. Our next speaker is Debbie James. And she is currently a clinical care learning specialist at the Southwest Texas Methodist Hospital in San Antonio, Texas. She has held various positions in critical care, including staff nurse, head nurse, and nurse educator for the last 23 years. Ms. James serves on the Bioethics Committee of the Methodist Hospital and the Bexar County Medical Society and is the founder and co-person of the San Antonio chapter of the International Association of Near-Death Studies. Ms. James was awarded the 1996 Excellence in Education Award from Sigma Theta Tau and the 1999 Excellence in Education Award from the National American Association of Critical Care Nurses. I present to you Ms. Debbie James.
First of all, I'd like to thank the Conference Planning Committee for having me here. I feel truly honored to be part of this very distinguished faculty. I participated last year as a speaker, and I learned so much. So for those of you who have never lectured before, trust me, you learn a great deal from doing any presentation. Now, I have friends in the audience, and because I need to make up time, many people who know me know that I can talk as fast as you can listen. So I will do the best I can. I often repeat myself as an educator because if a point is important, I think it needs to be brought up over and over. So if I talk too fast, somebody be obnoxious, raise your hand, throw something at me, so I'll slow down a little bit. Also, I want to make you a promise. I don't think I can hold a candle to your last speaker, but certainly I want to make a promise to you that I won't put you to sleep. At least I'll try. In your conference manual, under section number 3, there is a handout from me. And so I like to put things in there because I don't like for people to have to take notes. However, since I was asked to do this presentation, some things in terms of legislation have changed. So the handout is probably a little bit dated, but the slides will go with exactly what I'm going to be saying to you. So once again, thank you for being here, and at the end I will allow time for questions. And hopefully case studies, which I think help people learn the best, is what I hope to get the points across through. So, in looking at the Senate Bill 1260, which went to the governor May 21st for signature, we've found a number of changes in the current law. Now, this is meant to simplify and consolidate issues. Hopefully it will do that. But I've had the privilege of lecturing to a number of nurses, physicians, clergy, etc. throughout the country, and I find that there's a great deal of misunderstanding about some of these issues. So what I'll hopefully do is, rather than tell you the way things are right now, is discuss come September 1st, how will things be in terms of the law. So as you look at my growth and development in nursing, I can tell you that there's a number of things that I didn't realize, and I really didn't know where to go. So before we close today, hopefully I'll be able to give you some resources and some recommendations in trying to put together hospital policy, et cetera, et cetera, et cetera. I'm involved in those kinds of things through our bioethics committee. Also, if there's anything I say that you'd like a copy of, knowing that this Senate bill, this new law, is 67 pages, I'm going to only be able to touch the high spots of this. So if there's anything that I referred to that you think, tell me more about this, certainly at break I'd be more than happy to do that and give you more in-depth information about this. So first, in looking at the whole picture, when you think of patient rights, advanced directives, etc., let's get on the same page in terms of definitions and so on. So looking at patients and their rights, most of what we practice today comes from the Self-Determination Act of 1990. What did that say? Basically it says that every patient has the right to participate, make decisions about his or her own care. And so how do we make that happen? As your last speaker said, sometimes people take that decision away from us. They say, my mother isn't to know. Is that fair? It really isn't right. Again, in terms of definitions, what we used to call advanced directives, what we used to call advanced directives kind of were categorized in my mind as either what people were calling a living will or a directive to physicians, or somebody else speaking for us, which would be the durable power of attorney. That terminology has changed as well. And then also, most recently, we've had introduced to us the out-of-hospital DNR. So these are the three areas that have primarily been addressed in this new Senate Bill 1260. So let's go step by step. In looking first at advanced directive in the new legislation, first of all, we want to think that clearly through. So the directive itself is an instruction, and everything I have underlined on all the slides is new information or terminology. So a directive is an instruction made to administer, withhold, withdraw life-sustaining treatment, it used to say procedures, in the event of a terminal, the new term, or irreversible condition has been added. Now, people will say living will. They will call something an advanced directive. They'll also say directive to physicians. Some of these are synonymous, but people don't necessarily mean the same thing. If someone says, do you have an advanced directive, and you have a durable power, the answer is yes, but you don't have a directive to physicians. So again, this is a little complicated at times. The new terminology, instead of durable power of attorney for healthcare decisions, will be called medical power of attorney. This, all underlined, is new. A document delegating to an agent authority to make healthcare decisions. That's pretty straightforward. But some specifics to that. The medical power of attorney takes effect only when the attending physician certifies that the patient is incompetent. Otherwise, the patient could make those decisions. An agent designated for these decisions cannot consent through the new process to any of these things. Mental health services, electroshock therapy, psychotherapy, abortion, and then the omission or neglect of certain comfort care items. So somebody couldn't say, because this is costing my family so much, I want you to withdraw these procedures, medications, etc. from my father. That's not okay. Also, if there is no medical power of attorney for these healthcare decisions, as we've called them in the past, now medical power of attorney, the medical decision making devolves in rank order to the following: spouse, adult children, parents, nearest relative. Now I'll ask you, I heard a physician lecture about this. It was the first time I had really talked about it with anybody who had read this new stuff. And he asked the audience, who is the nearest relative? Would my aunt be closer than my cousin? Sometimes this is complicated. Well, I raised my hand and said, where do they live? And he said, it would take a blonde to ask a question like that. But sometimes we really don't know. Remember, these people who made up these rules are not practitioners like we are. They're making rules, and so what does nearest relative really mean? And how complicated can that be? If you've ever been involved with a large family who has to make decisions about anything, much less complicated decisions, you know where I'm coming from. Next is the out-of-hospital DNR. So first of all, what is it? It's legally binding. It is supposed to be put on a form that's been specified by the board. It should be prepared and signed by the attending physician of that person. It documents the instructions of the person or their designee. And it directs healthcare professionals acting in an out-of-hospital setting, we're going to talk about that in a minute, not to initiate or continue the following life-sustaining treatment. Again, treatment used to be procedures. Now we're going to talk about which procedures in just a minute. But first, I can't get away from this slide without talking to you for just a minute about what is out of hospital. The new wording still includes a private home, hospice settings, long-term care facilities, doctor's offices. But now it also includes hospital outpatient services and ERs. So that means that you probably need to update your policy in your hospital. That's what we're going through right now in the Methodist healthcare system, is updating how does this out-of-hospital DNR order work in the hospital ER. It can be a little bit complicated because if you have in-hospital DNR orders that are very different, or when they actually are implemented, those things need to be addressed. And again, this is all going to be effective September 1. Mm-hmm.
On the attending physician, does that exclude the hospice medical director? We're not stated as attending physician?
I can actually show you, I don't have it up here with me right now, but attending physician is identified in the new process. And I was, of course, thinking very in-hospital kind of focused. So we'll get that answer for you before the end. So everybody's clear then on out-of-hospital setting. So we'll go to then the actual processes, treatments that are involved here. So CPR, artificial ventilation, transcutaneous cardiac pacing, and other life-sustaining treatment. Notice that intubation and cardiac resuscitative medications is omitted from the last go-round of this law. So something, again, in terms of hospital policy may need, or your facility policy, may need to be addressed. Now, in the new legislation, there's not much really reference to in-hospital CPR, but I feel really remiss if I don't mention it at least a little bit. So what is CPR? I can tell you as a nurse trying to put together, I was given the job to put together 5 hospitals worth of information into a DNR policy that is effective in hospital. And I thought it was going to be hard, but I never had any kind of imagination of how hard. This is a very emotional subject. People have a lot of political and emotional feelings about it. And so first, let's look at the simplicity as it could be. I see it very clearly now after all the research that I've done in trying to put this together. But there are still people, as I educate them, that have great difficulty with the subject. So what is CPR and what is DNR or DNAR? Depending on from wherever you are, you might call it do not attempt resuscitation or do not resuscitate. Actually, first you have to start at the beginning, and the new legislation actually has the term CPR identified, and that is any medical intervention that would be given to restore cessation of circulation or respiration. So what I just said to you is, first you have to be dead. So by definition, any book will tell you that resuscitation is to restore life. Now, why is it so complicated? Because many of the issues we talk about in hospitals today, the patient is not actually dead. The patient does not have cessation of breathing and or circulation. An example, I did a class for a group of nurses at 7:30 in the morning on a telemetry floor in one of our hospitals, and the nurse felt very educated when she left the room. At 9 o'clock, a physician came in and wrote an order, full DNR. That was the order, full DNR. And the nurse thought, I don't understand this, so of course she questioned it, which she should. Sir, could you tell me exactly what you mean by a full DNR? And the doctor was a little angry and said, I mean if she arrests, don't do anything. And she said, okay, then I'm clear. So if she Brady's down and she's symptomatic, you want me to go ahead and give atropine? No, he said. Well, then she has VTAC and she's symptomatic. You want me to give lidocaine and progress to cardioversion? No. She said, then I'm not sure I understand. Because in order to resuscitate, the measures taken would be restoring life. Because once again, she saw it very clearly now. Her and the physician sat down and addressed all the issues of medications, other kinds of therapies that were in the pre-arrest condition. And when they were done, the physician said, I really understand now why you didn't understand my order. So what am I going to recommend before I close today? Communication is a big part of this thing. What do you mean when you say DNR? What does the family hear when they hear DNR? Do they think that means do not care? Have they had an experience in their past where someone was made a DNR in another hospital, and then what happens? They turn off the lights and put them at the end of the hall or transfer them out of a certain place. Then maybe they have a bitter feeling about DNR. That's not the intent. So what is your intent? What does your language mean when you're looking at these kinds of issues? So once again, I thought it was worth mentioning the actual language in the new bill about CPR, because certainly this impacts the DNR inside hospitals. So I'm going to ask you some questions so far. Are these myths, legends, are they fact? Okay, DNR patients must be transferred from the intensive care unit. Is that fact or is that a myth? Okay, I'm probably hearing both right now. I can tell you that it is not a fact, it is not true, but everything I'm giving you today is a result of experiences that I've really had. I was in an SICU and a nurse told me, now that the patient's DNR, we have to transfer her. And I said, why? And she said, it's part of our unit policy. I said, really? And she said, yeah. And I said, please show that to me. Well, she couldn't find it. Other nurses argued with her, that was not protocol. That was not policy. This nurse really believed it was. So her efforts, once the patient was a DNR, they needed the bed for other patients who needed to be resuscitated, and so get them out. That should really never drive your triaging of patients, your placement of patients. If when somebody calls from the ER, admitting office, OR, wherever it is, and says, I have a patient, and you need to get a bed, if you start looking and triaging all your patients and saying to yourself, oh, here's a DNR, we need to get them out, why was the patient there to begin with? Why is the patient in the unit at all? If a DNR patient requires intensive care, they should be in intensive care. If a DNR patient does not require intensive care, the patient should not be in intensive care. I don't mean to oversimplify it, but I mean to help you have your awareness raised to see how simple the issues really can be. And if you're looking at them from a focus of a label, this patient is a DNR, therefore they need to be on X floor. If there's something, a palliative unit, if there's something in your facility that promotes that and care changes a little bit, fine. But in most hospitals, at least in this area of the country, that is not the case. But if people believe that this is truth, then how are they practicing otherwise? When a DNR order is written, all care for the patient is discontinued. Hopefully you all think that that is not fact, but I can tell you, who would you think believes that is fact? Families. Absolutely. You're absolutely right. Families believe that, some because of real experience, some because of horror stories, some because of our behavior. If we say things like, I just gave you the example of, now that your mother has been made a DNR, we're going to put her on another floor, then all of a sudden something about the care issues have changed. The fact that this woman does not want to be resuscitated, or the agent, the legal next of kin, whoever it is, says, please don't do the following, should not impact caring, comfort measures, and that is very clearly stated. So, in our hospital draft policy that we've put together, it very clearly says, though the patient is a DNR, all measures regarding comfort, palliative measures, hygiene, etc., will be continued. So I challenge you, wherever you work, is it clear what will continue about the patient's care, or is it sort of gray and people can make their own decisions? I can tell you that experiences that drive my belief are things like, you talk to a family and you say, if your mother should arrest, hopefully they understand the word arrest means anything but go to jail. If they understand arrest, then do you want us to do everything we can? Now, most families say, oh yes, please do everything you can. Okay, let me make sure I have this clear then. If your mother's heart stops, you want us to go ahead and do the compression. Oh, please don't beat on her chest. No. Okay, if your mother stops breathing, you want us to put one of those tubes down. Oh, please no. She would never want to be on that machine or have that tube. Okay? If your mother's heart has a fibrillation, a dysrhythmia, or we need to shock her, would you, oh, please don't use those paddles. No. So far, they've just told us, please do not intubate, do compressions. Please do not do those things that I think sound scary. So no compressions, no defibrillation, no intubation. But please do everything. And you know what? They mean that. Please do everything. What they really mean, bottom line, is please care. And that's what we have to focus on. So some parts of the country have, rather than calling this thing DNR, whether it be in hospital or out of hospital, they say what we're gonna do. I think that's the best way to approach families, is to say, now that your mother's condition has gotten to the point that it is, what we're going to do is really work real hard to make her comfortable. Now, we won't do things that'll make her more uncomfortable and prolong her suffering, like resuscitation, and explain it in that manner. That helps families a great deal. If the patient has a living will, now what we're referring to as directive to physicians, he is automatically a DNR patient. Is that true or no? That is not true. The reason I brought it up is because I was doing a presentation about brain death and talking about different decisions near the end of life, and a physician said, I have an advance directive. It's specifically a living will, and I've also told my family what I want. Therefore, I am a DNR. The physician really believed that the fact that he had written this down, talked to his family, that it was automatically done, he was a DNR patient, and that's not the case. So if there's people out there, either in practice or families, patients, etc., that believe these kinds of things, we have to make it clear for them. Okay, also in the new bill, other terms have been identified. One is irreversible condition. Again, it's underlined, so it's all completely new. It exists when the individual has a condition that can't be cured, cannot make decisions, and requires life-sustaining support. So that's an irreversible condition. Also, a terminal condition is when death is expected within 6 months. Now, I know I've heard several physicians that are very resistant to saying this patient is terminal because they don't want to give the patient a death sentence. They don't want us to say anything regarding lack of hope. Sometimes this is very awkward for nursing staff because they're seeing, especially in their experience, they've seen these kinds of situations where the patient has literally died in the next month. But the physician has been resistant to making the patient a terminal patient, certifying that they're terminal, or whatever other language that you would like to call this. Artificial nutrition and hydration still includes, in the new wording, IV, subcutaneous, and also tube feedings. So again, this is a little bit clearer defined than it was in the last go-around. So when you look at so far the things I've mentioned to you, and this is the essence of the actual changes. So again, looking at the directive to physicians, the medical power of attorney, and out-of-hospital DNR. The rest of all the 67 pages is really to make this clear, give you some hints on forms, defining things clearer, etc., etc. And there's a lot more meat than I've been able to give you, but that's the kinds of things that are really there in terms of the essence. So what works? How do you implement these things? How do you put this new information to work? Well, one, education. You have to help other people see that this has come down the pike. Because I can tell you that there's a great misunderstanding about certain things. In presentations I've given, I've had physicians raise their hand and say, define terminal. It is clearly defined now. But if you ask an oncologist to define terminal, that might be a different definition. He or she might say something different than somebody from labor and delivery. So in terms of what we believe to be true, we all have to be on the same page to make anything work. Also changing hospital policy, doing things like putting pamphlets together, like decisions near the end of life for staff, and then better for families. So when they're coming in, they have questions asked of them about their advanced directives. If you have that, please, we have a copy of that to put in your chart, etc. We want to respect what you want. But more often than not, people don't have these, and they really do want to talk to somebody about it. So the best thing to do is have your staff educated to be able to talk or find the resources. There are people who feel, I just can't make all these decisions. There's just too many things going through my mind. How can I make this kind of decision? Well, then certainly implementing this new Senate bill, new information, as well as what should have been all along regarding patient rights, will be more complicated and hard to put into place. Barriers to success, to me, is one of the things that I could do a whole lecture on. Because to me, this is one of the biggest issues that we have problems with. Things that get in the way of successful implementation of advanced directives, of respecting patient rights, etc. Some of those, I have called this the ABCs of self-assessment. And to me, this is all about attitude, one's belief system, and then certainly last but not least is communication. So what is our attitude? And a lot of that was covered in this morning's presentation with the last speaker. What is our attitude about the person's meaning of life? What is our attitude about telling, truth-telling? What is our attitude about families calling the shots when the patient is incapable of making their decisions? So all of those things regarding attitude about ourselves, about the situation. If we say, I would never want to live this way, well, it's not about us. It's not about our ego. We have to look into what does this mean to the patient, to the family, etc. Is the timing of the situation so poor that if the patient died next week, it would have a different meaning to the family? So what's the attitude? What about the belief system? Do you hold the same belief system about this process, this condition, as the patient and the family? Again, that kind of goes with attitude. And then certainly the communication issue is a big one. If we're saying, like I gave you the illustration a while ago, do you want us to do everything for your mother? Meaning things like defibrillation, intubation, etc. The family only hears everything meaning kindness, etc. Lots of polls have been done throughout this country looking at what families in the waiting room want, what they believe, what they feel that they've been told or not. And I can tell you that I've been awe-inspired by some of this information. They feel like they're given so much information at one time that they're not really hearing anything. Well, that would make sense to me. When you ask families in waiting rooms, what do they really want? They identify 3 things. In every nursing study that I've ever read, they identify 3 things. The first, and sometimes it's the third, depending on what study you read, is I need information. What happened and what's going to happen. Next, I need information. Is the best possible care being given to my loved one? And third, I need to be there. So if we're talking to families who need information, and some of that information comes from, I have to see her. I have to see that it's that bad. I have to be in her death with her. Are we allowing for those kinds of things? Is our basic nonverbal communication, as soon as the family says, if he's dying, then I want to be with him in the moment. Well, but he's in intensive care, you can't do that. Well, why can't he? Etc. What are we saying by our very body language to the family when they ask for something like being present at death? I think the hospice movement, if we could get together with critical care and merge the 2 attitudes, beliefs, and communication systems, we would be just in a wonderful state of the art. But I'm not sure everybody's ready for that at present time. Working with families in crisis can be extremely difficult and certainly a barrier to making the success of putting in place all of these patient rights. If the family isn't ready for information, if the family is angry, if the family, etc., you might have some difficulty working with them. What is your experience level working with the family in crisis? How comfortable are you talking about certain information? Being able to use the word dead, death, rather than expire, terminate, etc. I always remind nurses that milk and cottage cheese expires, people die. And they need to hear that kind of thing. Also, what about conflict in the family? In situations that I can think of where you have a 17-year-old in the ICU and you have divorced parents, maybe they're remarried, etc. Sometimes that's very awkward because you're not sure exactly who you should be talking to. Sometimes there's such a conflict that it really doesn't matter what mom says as the custodial parent. Dad's going to disagree with it just because. They haven't agreed about anything for the last 8 years, so they're not going to agree about this child's care as well. That certainly makes issues of patient rights and discussions about their care very, very difficult. So that in itself could be a big barrier. Also, language. This is a little bit older terminology on purpose because we used to call one of the ventilators MA1. And so if that's comfortable for me now, okay, fine. But EEG, EMG, ECG, EKG, we're saying all these things to families, to patients, regarding what do you want next? What about treatments, procedures that we want to continue and follow or not? and they don't even really understand our language. They're so overwhelmed with all of this. One of the saddest stories that I've heard, it's a little humorous but sad. There was a nurse in the SICU who told me that she was very embarrassed because a very well-educated daughter of one of the patients came up and said, "Could you tell me when my father became a vegetable?" And she said, "Excuse me?" The father had just had a coronary artery bypass a few hours before. He was still intubated, he was still pretty groggy, etc. And so the nurse said, "I'm not sure I understand what you're asking." And she said, "Well, I heard those two nurses over there talking about my father and they called him a cabbage." That's the terminology we use in hospitals. That's the terminology we use in intensive care units, and it's very comfortable for us. But this girl, who's well-educated, heard her father be called a cabbage. A cabbage is a vegetable that you buy in the grocery store, and so therefore she needs to understand when did he become a vegetable. So I think we need to be really very, very sensitive to the words we use. And as was described in the last presentation, if you're watching somebody's face as you're telling them something and they look like they're not getting it at all, or if this is real sad stuff and they're staring, and you think most people cry at this point when I tell them, then do they really hear you? Do they really understand? And again, the issue of interpreters is something that really has to be underscored. Sometimes interpreters are not saying what we ask them to say, and so the person doesn't understand not only the language, but the point of the message. How we're working with families, how we touch them, how we allow them in, how we participate in the care of the patient certainly can be a barrier or something that can really make implementation of patient rights, advanced directives, very, very easy or difficult. I can think of numerous examples, and I'm going to give you a couple in the case study part of this, wherein because the way we worked with the family, and as the patient began to have a deterioration of their condition, the family member was really utilized in the care of that patient. The understanding of the process was completely there. And I can think of other situations where the family was really complying with visiting hours and really not involved in care and had a great deal of understanding difficulty. Recommendations that I'd like to give to you, certainly education, I can't overemphasize the importance of that. Our focus needs to be the same. We need to all be going in the same direction. If we have nurses and physicians that have a quandary about things, we ought to be able to do something about that. In the actual information in the Senate bill, there's lots of discussion about ethics/medical committee, and we'll get to that. We often are driven by litigation fears. We want to practice defensive medicine and nursing. And in this situation, that itself might be a barrier. I've seen many situations come to the Bioethics Committee where the kids want this and they really aren't abiding by what the parent wanted, and the other parent is deceased. And because of fear of those kids suing us, we start going a direction that is really not respecting the rights of that patient. If we are clear on the patient's wishes, and the kids say, no, that's not what she really wants, we really need to think, who are we trying to focus our care on? If the patient can make decisions, we really need to go where the patient is. So, some of the actual language then in the new information is talking about providers are being protected from civil and criminal liability in the course of honoring advanced directives. Now, in like manner, if you have your legal department, your risk manager, et cetera, look over your hospital policies. If your hospital policies are driven by this new Senate bill, by the rights of patients from Self-Determination Act, et cetera, you can feel pretty comfortable if you're looking at all this and that's what drives you, that even if somebody wants to accuse you of this, that, and the other, we all know in this room that somebody can accuse us of anything anytime they want. But to actually be successful in a suit, then they have to prove that we did something neglectful or in terms of malpractice. But if we're driven by the right thing, and I think that's pretty clear, doing the right thing is honoring what the patient wishes, then it would seem pretty clear. So, resources. What are resources to look at in terms of this whole process? That's where the new information brings up the ethics or medical committee. So, a provider, whether it be the facility or the physician, who will not follow the requirements, the wishes, the instructions of the advance directive should be really involved in the case or provide life-sustaining treatment only until the opportunity has been afforded to effect transfer to another care provider. So remain on the case, get somebody else to help out with the case, transfer the care, and then get off the case. Because refusal of a physician to honor an advance directive should trigger, and this is exactly how it's stated, an ethics or medical committee. Now why, for those of you who really don't know a whole lot about this, many hospitals in this area, in this country, are too small or who have not developed ethics committees. And so when the first draft went out to people to review, many people responded to the Senate that ethics committees were not in their hospital. They had their medical committee doing those kinds of things regarding ethical decision making and review, et cetera, et cetera. So that's why the language changed to ethics/medical committee. So again, in your facility, if a physician is not respecting the wishes of a patient, somebody should be looking at a medical or ethics committee meeting. When you see what's going on with the patient and it makes perfect sense to you, then great. But how about the family's understanding? It's my proposal that if you bring them along hour by hour, et cetera, then the big picture, so in terms of resources, if you need to bring other people in to help them understand, you can identify that earlier. You can identify when a family doesn't understand a certain situation. You can bring other people in, whether it be interpreters or somebody from social service, et cetera, to help understand what's going on in the situation of this patient's care. So, more questions for you. Myths, legends, fact, fiction. The attending physician certifies that a patient is terminal or a terminal or irreversible condition exists. Is that true or false? That's true. It used to be that 2 physicians had to say somebody was terminal, and that's present this very minute. But as of September 1st, 2 physicians will not have to certify this terminal situation. It will only be 1, and that's the attending physician. Advance directives must be written, signed, and notarized. Is that true? No. The actual new information tells us that the advance directive can be written, but it does not need to be notarized. It also can be verbal. It can be an oral wish that's expressed right now by the patient. That does require 2 witnesses, and those witnesses must be adults, one of whom cannot be a caregiver, a relative, one who will benefit from the estate, or one who has a claim against the estate, or one who's associated in the business functioning of the provider. So in other words, if you're a physician, your office staff could not be witnessing this information because they have to do with the business function of that provider. Okay? This really is simpler than it is currently at this time. 2 physicians must certify, so this is actually answering what I just asked you. 2 physicians must certify that a condition is terminal for an advance directive to be valid. That is true presently this minute, but as of September 1st, it will only be 1. Okay, an oral advance directive requires the presence of the attending physician and 2 qualified witnesses and is documented in the medical record with the names of the witnesses. Is that true? That's exactly how it's stated in the new Senate bill. Okay, so the patient can say it, but it must be said in the presence of, in other words, the nurses can't hear it, call the physician and say, guess what she just told me. It can't work like that. It has to be the attending physician and then 2 witnesses, and we've already described what the witnesses mean. Okay. A declarant may revoke an advance directive at any time, regardless of competency. Is that true or false? That is true. The patient can say, I changed my mind. And I'm going to give you an illustration of that in just a minute. I don't want to do that anymore. I do want to do that. And it doesn't matter whether they're competent or not. Mercy killing is not condoned. True or false? Absolutely true. Okay. Okay. Once a patient has been pronounced brain dead, the family must be asked to give permission to discontinue life support or technology interventions. Is that true or false? That is so false, but that is so practiced. In this city, I can tell you, I know from the healthcare system where I work, which is 5 hospitals, but I've networked with a number of people who are having great difficulty with this myth. Once a patient is brain dead, that is dead. We don't vent a dead patient. Therefore, a family should never be asked, can we remove the ventilator from your mother? What that does is make the family feel like they caused mom's death. Can we remove the ventilator, IVs, et cetera, from your son? Not possible. Because the family thinks that they are then the decision makers about that death. They aren't the decision makers. The patient is already dead. There is decisions to be made, though. Does the patient wish to be an organ donor or not? Does the family have insight to that information? And if the answer is yes, then the patient remains on the ventilator and all the advanced technology until such can be done. Otherwise, if the family says no, then all that advanced technology is removed. And does the family have a choice? Not about it being removed, but I feel like compassionate care would include saying to the family, now that we are in the situation we are and you've said no to donation, we'll remove all of this at 8:30. Would you like to be there? Would you like to have your priest come in before? Would you all like to, et cetera, et cetera. So you're asking questions regarding their wishes based on what the deceased would have wanted about all this. So again, in terms of patient rights, it's all there. The patient who requests fetal care as determined by the attending physician and the medical or the ethics committee becomes responsible for the cost of this care after 10 days. So if the patient says, I still want to have this surgery, even though everybody has said this surgery would be futile, it would absolutely not help a thing, then the patient would be responsible for that kind of care. It might be hard to find somebody to do that kind of care, but the point is, fetal care does not have to be offered and done. The absence of an advance directive does not create a presumption that an individual would desire fetal care. Is that true or not? Absolutely true. So, in terms of wrapping this up to the case studies, I know we're all striving for excellence. Sometimes it's very difficult to know all the rules, to be able to practice them within the framework, which was the intent of the rule. And so I think together we can come to some answers about striving for this excellence. So I thought what I'd do to promote questions and to kind of wrap this up is give you a couple of case studies. One was in a medical intensive care unit. And that's because the woman who we're talking about, the patient, 93 years old, she had an advance directive in writing. It was the directive to physicians. She also had one of her children as her durable power. She also let everybody know what she wanted. She did not want to be intubated. She presently had pulmonary disease that was fatal, and it was very hard to treat, and it was pretty rare. So she gets to the ER, brought in by EMS, and all these documents are in place, and everyone respects that. She is struggling to breathe. She has no family with her, and the ER doctor said, I understand that, and reviewed her rights and her advance directives. Is this what you want? And the woman said no, she changed her mind, she wanted to be intubated. The physician said, all right. So he intubated her. Her children started arriving. She's now in the MICU. This is where I got involved in the case. The physician who was taking care of her asked me to come in because the woman had now changed her mind again. Her husband had died 1 month before she was in this hospitalization, and she decided she really appreciated this doctor intubating her and the care that had been given over the last 24 hours, but she was done. She didn't want to do this anymore. And so she said, take it out. This woman could make her own decisions, was perfectly lucid. Her family was told what she and the doctor, now she's intubated so she can't speak to this, but some of it she was writing, and some of it was just questioning. The children were all at the bedside. Whenever I came in, the doctor introduced me as, this is Debbie, she's a nurse who's going to help me help you, which I thought was a very kind way of introducing all of the team players. And so the family, though sad, felt like they should respect Mom's wishes. She wanted to be removed from the ventilator right now. And so the doctor explained to the family, as I listened, about what would happen, what would be the process. And then asked me to reiterate some issues, and I did. And then one of the sons asked me, is this extubation thing, is this awful, is it painful? And I said, the process of extubation is not painful, but once she is extubated, it will look to you like she's suffering. And then the doctor said, so what I will do is give her medications that will keep her comfortable. We all discussed it, we all described it. The patient was in the bed at the time, listening. Once the family decided this was what their mother wanted, and yes, this is the right thing, the patient and the physician were looking at each other. The physician said, now you understand, if I take that tube out, you might stop breathing right away, or you might struggle to breathe just like in the ER yesterday. I understand. She shook her head. Is this still what you want me to do? Shook her head, yes. All right, then this is how I'm going to do it. Everybody was on the same page, in the same room, great respect. But my point in telling you her story is it was all decided before she got to the hospital. But she changed her mind, and she had every right to change her mind. And then when she's in the MICU 24 hours later, she changed her mind again, and that's okay. And we respected her, gave her her rights. Her family was very grateful, and in the next 24 hours, she did die. Case number 2, the patient is in the ER, intubated, when the son arrives. He is angry as he can be because he has in his hand, he's waving the paper saying, my mother never wanted to be on that, I can't believe you people, etc., etc. What's the mother's story? The mother's story is she has cancer. The cancer is just being treated beautifully. There is no problem with the cancer, but she has a terrible pneumonia. The pneumonia is what brought her in by EMS. She is now intubated, and the pneumonia is being treated. The son is still madder than a hatter, saying, take her off that machine, etc., etc. So explanation was given to him about, it's not about the cancer. Yes, she has a terminal disease, but she might die in 6 months, 2 years. We don't know for sure regarding the cancer. If we treat this pneumonia for 3 days, etc., etc., etc. So the son had to understand that we weren't going against the patient's wishes. The patient had a treatable process, and that was called pneumonia. So again, the respect of her wishes, she was not terminal from this insult that she came in with. And again, it was very hard to define all that. Took some time, took great communication with the son, etc. So, I wanted to remind you of the lady that I just told you about, the one that had the husband who predeceased her. And I can tell you that many times patients make decisions based on something like that. Now that my husband is gone, I don't choose to live on, etc. And they change their mind about what seemed to be very clear directives before this situation. So in conclusion, I would like to invite all of you to take the opportunity to read as much as you can about the new legislation, what's out there in the Senate bill, change your policies, procedures, and so on. Educate each other. Have great meetings where you really go way out there in the sky and talk about things that are even terribly hypothetical, but challenge your own self to learn about what we can do to respect the rights of patients the best we can. If there's anybody asleep next to you, please wake them up, because I promised I would try not to put you to sleep. With that, I'll ask if anybody has any questions, because we have just a couple minutes. Yes, ma'am.
You mentioned about the verbal DNR
Mm-hmm.
and who can and cannot serve as witnesses.
Mm-hmm.
It can't be a relative, is that
Right.
right? Or associated with the business of the provider.
Right.
Can you give some examples of who are good qualified?
Okay, now remember that's only one. Her question is about the witnesses. And right now, it says that the witnesses, period, can't be any of those people. But in the new way, one of those could be a relative, et cetera, but one of them cannot be. So, for example, a volunteer, another visitor, somebody who's not related to the situation at all is somebody that could certainly serve as a witness. And remember, they're only witnessing the signature. They're not saying they agree with this or anything. They're just saying, I saw her sign that. That's all. Yes, sir.
I've run into situations in the hospital where trying to get a witness who is not a nurse, I have people tell me to say, oh, only a nurse can witness that. And it is such a turnaround of what is actually required. I have people backing up saying that's policy, and they're constantly saying, oh, I can't witness that. You need a nurse to do that. And that happens to me all the time.
Okay, the advice I would give you is look at hospital policy, because there, excuse me? Oh, the question was about, he's had experiences of people saying that only a nurse could witness something. And there's other people that would say a nurse can never witness because the nurse has a conflict of interest working for the facility, et cetera, et cetera. My advice to you is please check your policy. If it's not clear, make it clear, especially based on these new guidelines. Because it is complicated to find two people who are totally unrelated to the situation. But it really isn't about nursing. It's only witnessing, I saw her sign that piece of paper. And it doesn't take a nurse to do that. But if your policy says a nurse may not do that, then that's what you should follow. Because you never want to be cited for not following a policy of any nature. Other questions? Yes, ma'am.
My second question is about the DNR. You specifically said that it means no CPR, no cardiac pacing, and no artificial ventilation, but it excludes administration of cardiac drugs.
Right.
And my question is, what's the rationale for giving a patient cardiac drugs who doesn't have any circulation? I've seen this in my practice where a family, very highly educated about what was going on, specifically requested giving cardiac drugs.
Right.
But no CPR.
Okay, I'm going to reword the question just very simply. She's talking about chem codes. I'm just going to say the term. Chem codes, slow codes, walk slows, in the medical literature it says that they are unethical and close to illegal. I agree with you. Her point was she's seen families who are very well educated who say things or question things like, if you say, I'm going to give your dad an injection of epinephrine in a distal IV line, but we're not going to do compressions. Somebody who has some intelligence about circulation would say, why would you do that? I've had physicians say to me, I need a chem code, do not remove it from the policy. And I say, why do you need a chem code? When someone is dead, we are not talking about Brady dysrhythmias and tachydysrhythmias when the patient is symptomatic. We're not talking that. We're talking about the patient is clearly dead. No breathing, no circulation. If you give a drug and don't circulate it, that's a lie. Why would you do it? Physicians have told me it makes the family feel better. I'm here to tell you, if you have to use something that's a lie to make a family feel better, question what you're saying. If you are telling a family something, we're going to put some medicine in here, but we're not going to make it work, we're not going to even get it to the central circulation, that's supposed to make a family feel better? So my answer is, I don't know. And we need to rethink if we're using chem codes to make us feel better. Sometimes it's, I don't know what else to do, so I'll inject some drug and hope that the family feels better about that. They don't, not if they understand what this is all about. One more question? One more question. Yes.
I have a question. In light of perceived threats about suits and litigations, how have hospital administrators responded to family wishes against patient rights?
Okay. In terms of case law, in terms of real case studies, I can't tell you that I know. Okay, the question is, and you help me if I say it wrong, the question is looking at case law. When you're looking at respecting what the patient says versus what the families want you to do, okay, and then litigation. Where is that? I can only tell you the sense that I have, and from what I've read and heard, that when a family is angry, they often sue. When a patient is angry, they often sue. So sometimes people tiptoe around situations and good communication sort of goes out the window, and that's really the point. As was illustrated in the last presentation, when you sit down with somebody and say, and what does that mean to you? And what does that mean to you? And why do we need to do this, et cetera, et cetera. There are kids who have said to us, he's going to live no matter what I have to do, and the patient is suffering, and the patient wants to die. This is about patient rights. And so if you're saying, if I was charged with something, if there was a litigious action, what would happen? I'm here to tell you that your hospital policy, the legal issues that are guided by these kinds of guidelines, Senate Bill 1260, that's the kinds of things that protect us. That's what should be driving us. So I know it's emotional and I know it's political. And it becomes more complicated when this is somebody who everybody knows in the city, like Sean Elliott. Everybody knows he needs a kidney. So how much privacy is he going to get? If there's decisions to be made about him, how difficult is it going to be to respect his rights? It shouldn't be difficult at all. As long as he can make decisions for himself, that's what should drive our practice. And once he can't, once he's incompetent, incapacitated, then the person who's his designee makes those decisions. And we don't have to like those decisions at all. That's where I would go in terms of just a global answer. As far as case law, I really don't know. Thank you very much for having me, and have a good rest of the day.